Lumbar sympathetic block commonly done for the lower abdomen and for the lower extremities. This is an injection technique of local anesthetic in the sympathetic nervous tissue. The nerves, which are the part of sympathetic nervous system, the nerves are located either side of the spine in the back. So it is the sympathetic chain at the lumbar level. If we see the lumbar spine, what you can see, lumbar spine is having its body. This is the body of the spine. Next, these projections are the transverse processes. And if we look at, we can see the other structure. Here lies the pedicle. This portion, again, this is the transverse process. This is the superior articular facet. These are the inferior articular facet. Going back, these are the lamina. This is the spine. In this area, as in the class of the sympathetic chain, it is told that anatomy of the sympathetic nervous system. The sympathetic chain starts from slightly towards the posterior side, like in the stellate, where you give in the junction of the transverse process and the vertebral body. As it comes down, it gradually comes anterior at the level of T2 T3 sympathetic level. You block it at the junction of posterior 1/3 and the anterior 2/3 of the vertebral body level. As we are coming down at the lumbar area, it is situated at the anterolateral corner of the vertebral body. So from behind, it is coming towards the anterolateral side, and then you all know the chains of both sides joined together below and forming the ganglia nympha. So to block at the lumbar sympathetic level, we need to go to the anterolateral corner of the vertebra. Now, if we think that we are coming from the back, how we can see at what are the structures we have to go and where we need to go. Now, this is the L1 vertebra. Lumbar sympathetic chain is usually blocked at the level of the L2, L3 and L4 level. Now, as I have told, the chain is coming through the anterolateral corner of the vertebrals. Now, the ganglions are situated closer to the L2-3 disc. That means the ganglion at the L2 level is situated at the junction of upper 2/3 and anterior 1/3 of the height, and it is at the anterolateral corner of the vertebral body, like this place. Similarly, the ganglion at the level of the L3 is situated at the junction of the upper 1/3 and lower 2/3 of the vertebra, and it is also situated at the anterolateral corner. The L4 sympathetic chain is most unreliable. That means the position is not always same, but it is usually located at the middle. That means upper half and lower half of the vertebral body, and again in the anterolateral corner. So we need to reach these areas, one here, one here, one here. So this is, remember, at the L2 and L3, they are closer to the L2-3 disc, and the distance from the L2-3 disc is upper 2/3, lower 1/3 in case of L2, upper 1/3, lower 2/3 in case of L3, and L4 it is almost at the middle. So in between the vertebra we have the disc, and we have to come from the posterior side. Now let us tell you the indications. First of all sympathetic blocks are commonly done in two indications that you need to remember. One are the vascular conditions. That means we all know sympathetic causes vasoconstriction. So any disease which is the result of vasoconstriction or causing vasoconstriction, then it's in vasodilatation. That means suppose a peripheral vascular disease. So if you block it, the sympathetic will be blocked, and that will help in vasodilatation. So we can say the circulatory indications, where it is the inoperable peripheral vascular disease, vasospastic disease of the lower extremities, and other one is the pain. That means sympathetically mediated or maintained pain. like neuropathic sprain, reflex sympathetic dystrophies. Nowadays, it is named as the CRPS type 1 or complex regional pain syndrome type 1, urogenic or pelvic pain, or any other visceral pain due to cancer, okay, phantom pain, herpes zoster involving the lower extremities. So these are the indications. Now coming to the contraindications. So what are the contraindications? Patients with anticoagulant therapy. It is a relative contraindication, not an absolute. Next is the hemorrhagic disorders, allergy to the medications injected, the local infection, local neoplasm, and local vascular anomalies. So these are the contraindications for the lumbar sympathetic block. Now, for the diagnostic blocks, things we need are this. Definitely, we will require local anesthetic, and usually 15 to 25 ml volume is injected. Usually, short-acting local anesthetic such as 1% lignocaine is commonly used for the diagnostic sympathetic block, and for neurolytic block, we can use 2 to 4 ml at both 3 and 4. Sometimes we require at the L2 as well, using 6 to 10% phenol, that is most commonly used, or 50 to 100% of alcohol. But most commonly used is the 6% phenol. Now, patient is placed prone and we have to put a pillow below the abdomen to make the posterior part of the vertebra stretched and to reduce the lumbar lordosis. And then the anatomic landmarks will be more stable and bilateral blocks can be performed more easily. Now, technique I will be showing in the patient, but before showing it, let us explain with this model how we are planning to go. So, we already described where we need to go. That means we need to go at the anterolateral corner at specific heights. That means at the L2-3 level, we will be going to the lower 1/3 upper through. I am not repeating again. So, if we want to go from posterior side, so only obstacle in our path are two. Number one, these things and the nerve root. Nerve root we cannot injure, and these are the transverse processes. Transverse process should not come in our way. Now, as in lumbar level, there is not much important structure, so we can easily make it oblique. And like you can see in this picture, we are making it oblique such as the transverse process comes within the vertebral body. So if your patient is sitting from the back, we are taking an AP view, it will be like this. Now if he rotate, now that means Siam is, we are making the Siam oblique. Now in this position, you can see now the transverse process is within the vertebral body. So if we go by making a tunnel here, tunnel view here, like that, like this, okay? So we will reach the area. So we are going to do like exactly the same in the Siam. So first step, like everything, every other lumbar procedure, here also our first step is the same. That means we are going to square the end plates. Patient is prone, we are trying to find the level. So this, the uppermost vertebra here, what you can see is actually the T12. So this is the L1, this is the L2, this is the L3, this is the L4. So I am showing at the level of the L2 and I am showing towards the left side of the patient, that means this side of the patient. So what I am asking that, okay. So again, let me show you, this is the L2 level. So now at this position, the L2 end plate is squared, the lower end plate is squared. So I do not require any squaring here. Only for the L4 I might need squaring, but L2 lower end plate and the L3 is mostly squared now. So what we are going to do, we are going to make it oblique so that this transverse process actually comes and within the vertebral body shadow. So he has made it oblique, and check. We need to move it slightly more. Now you can see the transverse process end here and the vertebral body end here. A little more. Okay. Now, as it is the end limit of the theorem, so what we can do, we can, in the patient, we can make the table, tilt the table, but here we do not have that advantage of tilting the table. So I am not tilting the table, rather what I am doing in the opposite side. Okay, so we will be doing in this side. Okay, slightly more, slightly more, slightly more. Fine. Now this is clear. This is the end of the transverse process, that is well within the vertebral body. So now if we measure this length, this upper 2/3 and lower 1/3. So this is the junction of upper 2/3 and lower 1/3. Let me draw, then it will be easier for you. So this is the L2 and we have to measure this area. This is upper 2/3 and here we have to make lower 1/3. So junction of the upper 2/3 and lower 1/3 is our place. Here we need to put the needle. So for that, what we are going to do, we are actually doing the same thing again. First we have to take a surface point. So with an opaque object, opaque marker, what I am doing, I am just putting this opaque marker to find out the entry point. So now I am putting an opaque marker here. All right, we need to go slightly more lateral, slightly down. Okay, so this is the perfect position and we need to go here with the needle. Now, which needle I am going to use? If you are planning for the local anesthetic block, usually 12 to 15 centimeter quincke spinal needle, that is the long quincke spinal needle is taken depending on the obesity of the patient. If the patient is too obese, you might require 15. If the patient is comparatively less obese, you can use the 12 centimeter. If the patient is even lean and thin, you can use the normal spinal needle as well. But in most cases, we will be requiring the 12, or if we are using the radiofrequency needle, we usually use the 15 centimeter radiofrequency needle. Now, again, the tip is bent slightly. So we have bent the tip slightly. Now we are going to put this needle. So first we are putting the tip exactly where it should be. Okay, and we need to put it along the direction of the CR beam. So if we try properly, we can make this tunnel view. So you can see this is the tip, this is the hub of the needle. It is almost tunneled. We are just trying to go like this. Okay, so we are moving away slightly. Now I will be moving the tip slightly towards the medial side. Okay, so here one tip is that here we need to go in such a way that tip remains close to our target and slightly more towards the vertebral body, because if we go away, then we may not be able to understand the depth. Okay, so we are closer to the site. Now again we are going. Now I am getting the feeling that I have just touched the vertebral body. So I am already in a depth and I have to go very slowly grazing the vertebral body. This position sometimes might be a little painful if you are grazing too much on the vertebral body. Check. Okay. So it is almost there, slightly towards the disc of the lower side, and we are near the vertebral body. So at this position, what we are going to do is we have to do it lateral. So now we need a lateral view. Okay, so the position is not final because we have reached only up to the side. So we need to move slightly more, and this last movement we'll be doing in this view only. That means in the lateral view only. Slowly we will move the needle towards our target. Okay, so slightly we are moving towards the target. Okay, so we should not go much beyond. We should be there at the junction. So that is almost final position. If I could move slightly little below, then it is obviously it is better. Here it is near the middle. So if slightly below, it could be better, but it is not a problem because as we are giving local anesthetic and steroid here for the diagnostic, it will definitely cover this area. So it won't be a problem, but definitely slightly below would be better. Now you have to check in the anterior posterior view as well. In the anterior posterior view, you have to make sure that the needle is well, it is not outside, it is well within the vertebral body. So you can see it here. So this is the final needle position. And at this place, we need to inject dye. And this is the picture after the injection of dye. So this is the dye spread, and if we have seen this type dye spread, then we are confirmed. Now we have to use our injected. Okay, so if you are going for the diagnostic block, we will be giving steroid local anesthetic. If we are giving the neurolytic, then we will be injecting neurolytic drugs. I have already told these are the drugs for the diagnostic. Usually one level we do, and it is, if it is giving response, then it is fine because we are giving 15 to 25 ml. That spreads the whole area. And 1% lignocaine commonly used for the diagnostic sympathetic block. For neurolytic, 2 to 4 ml. Both L3 and L4 using 6 to 10% phenol is commonly used. So these are the drugs we need to inject, and then we have to come out. If you are injecting neurolytic, if you are using alcohol especially, then you have to, before giving alcohol, prior you have to give the local anesthetic injection. If you are not using alcohol, if you are giving phenol, there is no need to give prior an analgesic. Then you inject 6% phenol, inject a very small volume, 0.5 ml, so that the needle is washed of phenol, normal saline, and then take the needle out. If you are doing a radiofrequency ablation, then at this point, go for the stimulation, both sensory and motor. Here, as it is a mainly sympathetic block, you may not find any movement. Actually, if you are getting any movement in the legs, that is dangerous. So we are not expecting anything. So once we are done and we are seeing that leg muscles are not moving, then we can give local anesthetic first. Then we have to do the lesioning at 80 degrees Celsius for 90 seconds. And in radiofrequency, we do at all 3 levels. So that was the technique. Now coming to the complications. The most troublesome and frequent complication is simultaneous blockage of the L2 somatic nerve root, inadvertent injection into the subarachnoid space, epidural space, intravascular space. So if you are not careful enough, if you have not checked with the dye, then you might go to these areas. And with the damage, with the needle that you might do, with the neurolytic solution to kidneys, renals, previous ureter, right intervertebral disc. So you have to be careful, and if you are doing under fluoroscopy and carefully, then these chances are comparatively less. Now, other complications of the infection, retroperitoneal hematoma, destruction of the sympathetic fibers, producing cramping or burning pain in the anterior thigh, sympathetic mediated hypotension. So for the lumbar sympathetic block, it is comparatively less. If you do the celiac plexus block, it is much more. So usually we preload to avoid this, and failure of ejaculation, that might be another complication.